Let's talk about pad placement and specifically what you're trying to accomplish with pad placement. What you're trying to do is get as much energy through the left ventricle as possible. Not to the left ventricle, but through it. Because if I put a pad here and a pad here, I might skip energy across the left ventricle, but I'm not getting energy through the left ventricle. That's why with anterior lateral placement, what recommendations are, what the AHA recommends is your anterior pad or your sternal pad goes just below the clavicle and to the right of the sternum. And then your lateral pad or your apical pad, which is the pad that is most commonly misplaced, goes just below the pectoral line. And if your patient is a woman, it goes below the breast, always below the breast, but not anteriorly. That is a very common misplacement, is either the pad being too anterior or too inferior. That pad needs to be drawn back as far back as you can get it without rolling the patient. And the way to look at it is you want to consider that apical pad or that lateral pad to be a catcher's mitt that is catching a ball that is being pitched through the largest part of the left ventricle. This is what we call the vector. The defibrillation vector is the imaginary line that we can visualize going from one pad to the other. And when we visualize that pad, we want to see it crossing over and through as much of the left ventricle as possible. And so when you're visualizing that vector, if it's not crossing over and through as much of the left ventricle as possible, maybe it's too high, or maybe it's too low, or maybe this apical pad isn't where it's supposed to be, maybe it needs to be moved towards the mid-axillary line, then you need to fix that, preferably before your rhythm check, but it's okay to keep compressions going for a few seconds to fix it. We want that defibrillation attempt to be a perfect defibrillation attempt.